Okay, let's get going.
All right.
All right, folks, welcome to Cancer Center Grand Rounds. Today, we are going back to the old format, not old format, but the format of when we have local people. And we have two presentations of groups that are highly crucial to the Cancer Center, Cancer Hospital, and Cancer Enterprise. One is GI oncology and the role of the gastroenterologist, and the second is cardiac oncology and the role of cardiology. As we use more drugs, more targeted agents, more immune modulators, what we're finding is our patients, from the immune standpoint, are running into all kinds of problems with both liver toxicity and diarrhea and other kinds of issues in the GI tract. And having gastroenterologists embedded and intimately involved in what happens in the cancer center is crucial. And as we use more kinase inhibitors, we're finding that they got this little problem with occasionally causing cardiomyopathies, occasionally causing QT prolongation, and causing other issues with the heart itself that we really rely on the value of our cardiac consultations. So first, our first speaker will be James Farrell. James is director of the Yale Center for Pancreatic Disease, and will talk to us about the role of endoscopic management of pancreas cancer. Following James's talk, we'll hear from Raymond Russell. Ray Russell is an associate professor of medicine and diagnostic radiology, and his talk is Between a Rock and a Hard Place, the role of cardio-oncology in optimizing the care of patients with cancer. Dr. Farrell.
Thanks very much, Dr. Lynch. So my task this morning is to talk about endoscopy and the management of pancreatic cancer. I'm a gastroenterologist and interventional endoscopist by training, and as you can tell, that a lot of the different aspects of pancreatic cancer are really already been involved with endoscopy with respect to the diagnosis of the disease, staging, the stenting for relief of biliary obstruction, and also actually in the active treatment and palliation of the disease. So rather than kind of going over all of these laboriously, what I really want to focus on are kind of newer areas within these headings, within the areas of diagnosis, staging, again, biliary stenting, treatment, and palliation. So with respect to diagnosis, let me tell you about a 50-year-old woman with 3 attacks of pancreatitis. And she'd undergone a variety of CT scans. This is a good quality CT scans. This is just one of them, showing essentially a normal pancreas. She subsequently underwent an endoscopic ultrasound. And even though most of the exam was normal, we ended up focusing in on a 5-millimeter area in the pancreatic body. So it just didn't look like everything else should be looking. And we biopsied it with an endoscopic ultrasound biopsy. And this is the needle being traversed through the stomach wall into the mass, and we're collecting some cells. And what I actually confirmed was not a definite diagnosis of pancreatic adenocarcinoma, but it was said to be suspicious. But suspicious enough for us to send her to a surgeon who wanted to do a laparoscopic resection of this. So we also, in addition, placed an India ink tattoo in the area because the surgeon wasn't going to be able to find this area. And we placed it just upstream of where the lesion was by endoscopic ultrasound. So we would never see this lesion using traditional CT scan. In fact, it hadn't been seen on 3 successive CT scans. So after tattooing this area, we sent the patient for surgery. And what she ended up having was an IPMN, which is a type of cystic neoplasm of the pancreas, with carcinoma in situ, so the one step prior to invasive cancer. And this was over 5 years ago. So this is kind of the holy grail of early detection, is not so much to find cancers, believe it or not, at a resectable stage, but to find precancers at a dysplastic stage. And she continues to do well. But unfortunately, these are kind of rare instances in the world of pancreatic cancer screening. So what we've done in the past and what's opening up here again soon is a pancreas cancer screening study, a multi-center study involving about 5 or 6 high-volume pancreas centers in the Northeast. And we're looking at a variety of patients who we know are at increased levels, are increased risk of developing pancreatic cancer. And they include, believe it or not, if you just have a family history of pancreatic cancer without any actual genetic defect known, but just having pancreatic cancer run in your family puts you at an increased risk. Obviously, if there's a genetic mutation such as the BRCA2 gene or the P16 gene, there are familial breast ovarian cancer patients who also have an increased risk, as well as Peutz-Jeghers. And what ends up happening when these sorts of studies, and this will be the CAPS-5 study, will be very similar to what went on before, where patients get serial CT scans and MRIs, but also those endoscopic ultrasound studies that I showed you. They give a lot more detailed information about the pancreas. And in fact, in the CAPS-3 study, it was interesting to know that the most common finding found these are now family members of patients who have pancreatic cancer. So not patients with pancreatic cancer themselves, but asymptomatic family members of high-risk individuals. The most common finding were these incidental cysts. So there's this link between these incidental cysts, which we know are probably IPMNs, and the high-risk phenotype of high-risk familial pancreatic cancer. So that's the reason for doing the additional study, is to get more information. It's just interesting to note that in the original CAPS-3 study, which was one of the first large multi-center high-risk pancreatic cancer studies that was done, pancreatectomy was performed in 5 patients. No cancers were found in any of these 5 patients, but all of them had these high-grade or just pre-invasive cancer Pannon lesions. So it's 5 out of about 200 patients or so. It's still low percentages, but obviously if you're one of those 5 patients, you benefited from it. So in addition to diagnosis then, an early diagnosis, this is one of the workhorses seen in endoscopy with relation to pancreatic cancer, is our ability to pass an endoscope into the stomach and pass a small needle in through the stomach wall or the duodenal wall into a pancreatic head mass here. This is acidic fluid, which we can tap here, lymph node biopsies, which we can tap here, and also if we see liver lesions, we can biopsy them as well. So that's pretty standard routine, and we typically get a cytologic aspirate. What's changed, however, is what we are using. And so what we'd normally have used are these small standard needles, 25 gauge needles. This is a 19 gauge needle. And as I say, we get this cytologic smear that our cytologists here are very expert in looking at. But if you want to do additional work, special stains, some sort of quantitation, cytology is actually quite difficult to work with. So what's evolved over the last 2 or 3 years now are more defined core biopsy needles. So now we're getting very akin to what a radiologist or a surgeon would do by our ability to get core tissue. And this is, for example, down here, these are the core needles that we can pass using an endoscopic ultrasound. Down here are the core biopsy samples. So over here you get a smear of cells, but over here you're beginning to get architecture. In addition to architecture is the ability to get several sections from the pathologist for different studies. To give you an example, this is a particular patient who has a history of alcohol use and had a diffusely abnormal pancreas, and we're thinking this was all chronic pancreatitis. And we ended up doing a core biopsy. So you get a sliver of tissue from the pancreas like this. And in fact, on the original read, the pathologist took a slice through the core biopsy, and they read it as chronic pancreatitis with features of autoimmune pancreatitis, which is a type of chronic pancreatitis. And we asked for additional stains because we were interested in the autoimmune phenomenon. And when they did additional sections down through this, what they ended up finding was this moderately to poorly differentiated adenocarcinoma that wasn't picked up on the initial one, may not even have been picked up on cytology. So these core biopsies are beginning to kind of be game changers, at least in our diagnostic realm. The other area for endoscopic ultrasound that's also changing is staging of pancreatic cancer. Now, for when a patient presents originally, only about 10 to 15% of patients with pancreatic cancer are truly resectable. And it's often a lot of workup is involved with determining that. And a good quality pancreatic protocol CT scan is very useful for that. And over here on the left-hand side, for example, we have a pancreatic mass that appears to be somewhat away from although it's close here to the SMV and the SMA, and separate here from those vessels. And over here on the right-hand side, the mass is clearly involving the portal vein, and these patients are unresectable. So we don't really use endoscopic ultrasound for this indication. But now some of you are familiar with the fact that we're actually taking borderline resectable patients, and sometimes truly resectable patients, giving them a stretch of chemotherapy for 3 to 6 months, and then reassessing the resectability at that stage. So this is something now that's evolved over the last 4 or 5 years, but the push now to take truly resectable patients and give them some form of downstaging or neoadjuvant treatment is really a new concept. Now, if you look at these 2 patients, for example, these are 2 patients who've had chemotherapy for established pancreatic ductal adenocarcinoma. On the left-hand side is a question of possible SMV involvement, and on the right-hand side over here is a question of SMA involvement based purely on the CT scans. So if you were to follow just the CT scans in these patients, you would say, they had their treatment, they still look like they're unresectable. But what we're finding is we don't actually know what post-treatment CT scans mean in this scenario. So these patients then subsequently had endoscopic ultrasounds, and there was no SMV involvement in this patient and no SMA involvement in this patient, and both patients underwent surgical resection without venous or arterial involvement. So this is kind of another game changer coming into play now with this use of neoadjuvant or downstaging treatment. With respect to biliary stents, there are two types of biliary stents we use for the palliation of pancreatic, or for the management of biliary obstruction associated with pancreatic head lesions. On the left-hand side here is a plastic biliary stent that goes in. They're very cheap, but they last only about 2 to 3 months. Over on the right hand, this is what they look like. They're about 10 French or 8.5 or 7 French. Over on the right-hand side are these self-expanding metal biliary stents. They go in small, but they can expand up to 10 or sometimes 12 millimeters. And this is it being deployed over here. It goes in as a narrow sheath, and then the sheath is pulled off over it as it expands inside the bile duct and stricture and opens it up. And these are 3 different types in here. There's an uncovered type, which has absolutely no covering on it. It's just like the typical cardiac stents. Over on the far right-hand side is a fully covered stent, and these stents have a permalume cover around them, and the issue is to prevent tumor ingrowth, and that's the big problem that these uncovered stents have. So this stent is to overcome that, and then there's a halfway house, believe it or not, of these partially covered, because some of the problems with the fully covered stents is that they migrate, because they don't really have anything to anchor into. So this is kind of just a small primer on biliary stents. So let me just ask you a couple of questions to see how many people are familiar with this. So if you had a patient with operable pancreatic cancer and bile duct obstruction, would you even place a biliary stent? So you have a patient who's jaundiced. How many people here would place a biliary stent as opposed to definitely not place a biliary stent? So many people here would place a biliary stent to relieve the jaundice. Okay, so a couple of hands. So that was the standard of practice for quite some time. And then a very interesting study came out of Holland about 4 years ago, where they looked at this issue of preoperative biliary stent placement in patients who were on their way to surgery. And it turned out that the rate of complications even before surgery and after surgery was much higher in the stenting group. And so if there's patients who are on their way to surgery within a reasonable period of time, they're not cholangitic and they're not pruritic, we're now adopting the process of not stenting them, because it's primarily a cosmetic issue. So that's one change in practice for people to be aware of. If there's a patient with borderline resectable pancreatic cancer undergoing prolonged neoadjuvant treatment, so I talked to you about this, would you like to place a plastic biliary stent or a metal biliary stent? So these are patients now who've got 3 or 4 months of treatment ahead of them. We're not taking them to the operating room. Would it be better to place a small plastic stent or a bigger metal stent? Who would say a plastic stent? And who would say a metal stent? So a bigger metal stent is probably the way to go here in terms of the patency, keeping it wider for longer and allowing the patient to have essentially uninterrupted chemotherapy for those 3 months. When you put plastic stents in, we say 2 to 3 months, but as often some of you know, the patient will be back after a week for another stent change, their chemotherapy is interrupted, and so on and so forth. And finally, for patients with inoperable pancreatic cancer, what's the stent of choice here? Should you put an uncovered, partially covered, or fully covered? And to be honest with you, there's pros and cons to each of those. These ones, as I said, they get tumor ingrowth. These ones migrate. And this often now is a more preferable one, especially if the patient is not going to the operating room. So the real reason to place a metal biliary stent is this is a patient who has a plastic stent placed for their biliary obstruction, but when we went back in to change it, they had developed duodenal obstruction. And this is their plastic biliary stent. And what we ended up doing was placed a metal duodenal stent into the duodenum, and then we dilated that duodenal stent up, and this is the dilation of the duodenal stent. And after dilating it up, we passed our endoscope all the way down into the second portion of the duodenum, and there's that clogged plastic biliary stent that's really not doing the patient any good. And we ended up removing that. And so it's just kind of a call out to try and not use these plastic stents as often, because sometimes when we go back after 1 or 2 months, the patient's disease has progressed and we can't even get to the plastic stent to change it out. So we're able to remove this plastic biliary stent, and I won't prolong this video, but essentially placed a fully covered metal biliary stent there. This is another case. This is what I've already alluded to. This is a patient with unresectable, locally advanced pancreatic cancer. This is the stent, metal biliary stent that had been placed. If I can see that. They had 2 months of chemotherapy and a 50% decrease in their CA19-9. And then the stent looked a little bit odd to us. So when we went back, this is what a 75% migrated, fully covered stent looks like. You know, there should only be about 1 centimeter of it showing, and here there's about 5 centimeters showing. But as luck would have it, these stents are designed to be removed, so we can easily ensnare this with a standard endoscopic snare, like this, and pull this back into the scope. And so this we're seeing more and more with neoadjuvant and more importantly, effective treatment for pancreatic cancer, whereby some of the strictures are, I won't say they're absolutely melting away, but for sure the stents are migrating out. And then I think in this patient, we actually, just to play safe, we actually did place plastic stents because we didn't want the stents to migrate again. Okay. So I'll briefly say something about EUS-guided treatment for pancreatic cancer. It's very tempting to want to, instead of just diagnose, is maybe assist in the treatment of pancreatic cancer. And there's a variety of agents that have been used over time. I've been involved with some of these studies, the Onyx 015 study, the Teneferade study, which is a TNF-alpha associated with a radiation-inducible promoter. People have even been injecting gemcitabine, almost like out of frustration, directly into the tumor, and a variety of siRNA drugs as well. None of these trials, when they've gone to the stage of a randomized trial, have actually shown to be effective. But maybe some of them have been quite effective locally. So Teneferade actually is quite effective locally with some complete responses in their large studies. But I just bring it up there is that it's been very tempting as a gastroenterologist to want to do this, but none of the suitable agents that have been presented to us so far have really worked in their existing setting. So this is EUS-guided treatment. However, there's an evolving world of EUS-guiding treatment, or the world of personalized medicine for pancreatic cancer. Over here on the left-hand side, this is an area that I've been involved with HENT1. HENT1 is the human equilibrative transporter, which is the predominant mechanism whereby gemcitabine gets into pancreatic cancer cells, at least. And this is a cytologic specimen from a pancreatic cancer, and this is brown staining. This is a positive HENT1 specimen, and this is a negative HENT1 staining. And as I mentioned before, we now have the ability to use these core biopsies to get bigger chunks of tissue and maybe to begin to quantitate the tissue a little bit better for these markers. And so what we've begun to do is look at more quantitative immunohistochemistry using these core biopsies, and these are the matching patients. So this is the core biopsy from this patient showing positive HENT1 expression, and again down here is a core biopsy taken from the same patient not showing HENT1 expression. So it's not clear whether HENT1 will be the glorious marker for gemcitabine, but certainly within other areas there are certain other tumor-based markers that people are interested in, including ones related to DPC4 or SMAD4, and then the evolving area of stromal-based treatments and people looking at SPARC and high hyaluronidase as those treatment trials come along. So I think our ability now to get core tissue from these patients either preoperatively or patients who've got locally advanced disease is certainly seen as a game changer to at least assist you in the design and conduct of these trials and ultimately into patient care. Finally, the other aspect of treatment is EUS-guided fiducial placement marker for radiation oncologists when they want to really target their radiation treatment to avoid surrounding tissue damage. And when they have the ability to backload these gold fiducials into those biopsy needles and to deliver them very effectively by EUS into specific areas to outline the perimeter of a pancreatic neoplasm. Finally, into the world of palliation, I've already mentioned this. This is our ability to place an endoscopic stent for patients with pancreatic cancer. So for a lot of patients who have pancreatic head cancers, in addition to biliary obstruction, one of the biggest problems these patients develop is nausea and vomiting and gastric outlet obstruction related to the pancreatic head tumor. And so typically this would have been managed by surgery and some form of surgical bypass. And in the year 2014, the vast majority of these patients are now managed by the placement of an enteral stent endoscopically without the need for either open surgery or either laparoscopic surgery. The other area for palliation is the development and the delivery of nerve blocks. So another major problem that these patients who have either locally advanced or metastatic disease is really very severe pain. They're often on a variety of narcotics, the side effects of those narcotics. And so just like an interventional radiologist or the anesthesiologist can deliver these nerve blocks, EUS has a very accurate ability to locate the takeoff of the celiac artery. We're sitting here at the GE junction. We can identify the takeoff of the celiac artery, which is this blood vessel here. It's surrounded by the celiac ganglion, and we can inject combinations of bupivacaine and alcohol to really ablate that. And the data shows that really at about 2 weeks or so, there's anywhere between 75 and 85% reduction in pain control. But what that practically means is getting patients off their other pain medications and lessening the side effects. Some of us have experience with actually identifying the celiac ganglia themselves and directly injecting them. It's much more effective, but the patient often for the first 24 hours has a very severe exacerbation of their pain, but it's something we consider doing. So I'll summarize and say, for endoscopy and pancreatic cancer, most of you are familiar with the very established roles that have evolved over the last 15 to 20 years. But there are these new roles in the areas of early diagnosis, high-risk screening, the ability to get tissue core biopsies, the issue of staging, not so much before treatment, but after treatment to see whether or not a patient can be resectable, the evolving area of preoperative stenting, or rather the lack of preoperative stenting, our ability to place metal biliary stents for the duration of a neoadjuvant course of treatment, and then kind of the ever-evolving but sometimes frustrating area of EUS-guided and EUS-guiding treatment for pancreatic cancer. Thank you.